Hi, this is Amber Knowlton. This is for Nursing 2212, Unit 2, Chapter 29. This is the Pathophys of COPD. So, COPD is a preventable and treatable disease characterized by persistent airflow limitation that is slowly progressive. It is associated with an enhanced chronic inflammatory response of airway and lungs to noxious particles, primarily caused by cigarette smoking. COPD also results in some significant systemic effects that contribute to the severity of disease exhibited in individual patients. Previous definitions of COPD encompass two types of obstructive airway disease: chronic bronchitis, which is the presence of a chronic productive cough 3 months and 2 consecutive years in a patient who other causes of that cough have been excluded. And another previous definition of COPD encompassed the term emphysema, which is an abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of their walls and without obvious fibrosis. Only about 10% of COPD patients truly have emphysema. Patients may have a predominance of one of these conditions, but in reality, this is often difficult to determine because they usually coexist. COPD patients may have asthma. Asthma may be a risk factor for COPD. An estimated 12.7 million adults in the United States older than 18 have COPD. Persons with COPD are greatly underestimated because the disease is usually not diagnosed until it is moderately advanced, and it is the third leading cause of death. So, risk factors for COPD: cigarette smoking, occupational chemicals, dust, air pollution, infection, hereditary, aging. So, cigarette smoking is a major risk factor for people greater than 40 with a smoking history of 10 or more pack years. COPD should be considered. COPD is more than 4 times as prevalent among smokers as non-smokers. Cigarette smoking causes hyperplasia of cells. It increases mucus production, reduces airway diameter, makes clearing secretions difficult, decreases ciliary activity, destroys alveoli. Cellular changes can occur, developing into precancerous cells. There's chronic inflammation. There's structural changes to the lungs called remodeling. Cigarette smoking causes oxidative stress, so it changes the ability to protect the lungs. And passive smoking, secondhand smoking, causes decreased pulmonary function, increased respiratory symptoms, risk for pneumonia, and risk for lung and sinus cancer. In your book on page 582, table 2916 talks about the effects of tobacco on the respiratory system. Here are some effects of nicotine: increases the heart rate, it causes vasoconstriction, increases blood pressure. It decreases the amount of functional hemoglobin and increases platelet aggregation. So this combination leads to problems with coronary artery disease. And these are the problems that we talked about cigarette smoking causes on the respiratory tract. Cigarette smoking also decreases the oxygen carrying capacity, increases heart rate, impaired psychomotor performance and judgment, and we talked about the risks of secondhand smoking. So, occupational chemicals and dust and air pollution. Prolonged exposure to dust, vapors, irritant fumes in the workplace can develop COPD. Smoking with these environmental exposures even more increases the risk of COPD. Outdoor air pollution is a risk factor for COPD. Use of coal, other biomass fuels for indoor heating and cooking are a risk factor. Many women, particularly worldwide, who have never smoked are developing COPD from cooking with these fuels in poorly ventilated areas. Severe recurring respiratory tract infections in childhood have been associated with reduced lung function and increased respiratory symptoms in adulthood. While it is unclear if recurrent infections in adults are related to development of COPD, people who smoke and also have HIV have an accelerated development of COPD, and TB is a risk factor for COPD development. Antitrypsin deficiency. It is a protease inhibitor. It's a serum protein produced by the liver and normally found in the lungs. Its main function is to protect normal lung tissue from attack from an attack by a protease during inflammation related to cigarette smoking and infections. Severe antitrypsin deficiency leads to premature bullous emphysema in the lungs found on x-ray. Emphysema occurs because of this deficiency, and lower levels of antitrypsin result in insufficient inactivation and subsequent destruction of lung tissue. Clues to an antitrypsin deficiency are defined about the age of 40, and those patients by the age of 40 that are developing COPD symptoms with minimal to no tobacco use and family history of emphysema. A simple blood test can determine if you have an antitrypsin deficiency. Aging, as people age, gradual loss of the elastic recoil of the lungs occur, along with stiffening of the chest wall. There's alteration in gas exchange, a decrease in exercise tolerance. The lungs are rounder, they're smaller. The number of functioning alveoli decreases, and our peripheral airways lose supporting tissues. These changes are similar to those seen in the patient with emphysema. Clinically significant emphysema, however, usually is not caused by aging alone. So the pathophysiology of COPD. COPD is characterized by chronic inflammation found in the airways, the lung parenchyma, the respiratory bronchioles, the alveoli, and the pulmonary blood vessels. In your book on page 583, figure 29.8, there's a map that outlines the pathophysiology of COPD. The pathogenesis of COPD is complex and involves mechanisms. Defining feature, it's not fully reversible airflow limitation during forced exhalation. So what that means is the patient's unable to expire air is the main characteristic of COPD. The primary site of that airflow limitation is in those smaller airways. So the volume of residual air becomes greatly increased in severe disease as those alveolar attachments to small airways are destroyed. The patient tries to breathe in when the lungs are already overinflated. This gives the patient then becomes dyspneic, exercise capacity is limited. In this picture here, you can see the differences in gas exchange abnormalities that result in hypoxemia and hypercarbia. So they have low levels of oxygen, high levels of CO2 as the disease worsens, as the air trapping worsens and alveoli are destroyed. Bullae, which are large air spaces, and blebs, which are air spaces adjacent to pleura, can form. Patients have excessive mucus production resulting in a chronic cough, chronic bronchitis. They have a loss of alveolar walls and capillaries, so there's increased pressure in pulmonary circulation. This, along with thickening of blood vessels, results in pulmonary hypertension. Patients also will have systemic effects, including cachexia, which is skeletal muscle wasting. Osteoporosis, diabetes, metabolic syndrome, which cannot be readily related to smoking.